Good morning, everyone, and thank you so much for joining us for QI Power Hour. This is Tracy Sharon with the Saskatchewan Health Quality Council. For those of you joining us for the first time, QI Power Hour is Health Quality Council's free monthly webinar learning series. We bring together improvers from a variety of sectors, all with an interest in improving health and healthcare. I am joining you today from HQC's offices in Saskatoon on Treaty 6 territory and the homeland of the Métis. At Health Quality Council, we serve all peoples in Saskatchewan, which also includes traditional lands that are parts of Treaties 2, 4, 5, 8, and 10 as well. And my colleagues today will do another land acknowledgement shortly within the presentation, so I'll leave them to do that later as well. All of our QI Power Hour sessions are recorded and posted on Health Quality Council's website, so feel free to check that out to visit past sessions or to have another listen to this session once it's posted. And while you're there, please sign up for our QI Power Hour email newsletter so you can receive notices about upcoming sessions and details on how to register straight to your inbox. We are very excited to see the continued growth of QI Power Hour throughout our home province of Saskatchewan, across Canada, and around the world. And so we thank you so much for taking your time to join us today to learn and improve together. We are very much looking forward to your engagement and participation on the webinar today, and you can do that by using the chat function. I see a number of folks have already indicated where they're joining us from today in the chat. Thanks so much for doing that. Please continue sharing in the chat. If you're not sure how to do that, there's a little chat bubble. It looks like a speech bubble in the bottom right-hand corner of your screen. You can click on that, and then just please be sure to send your message to everyone so that we can all see it. Feel free to share your thoughts, your comments, your questions, and ideas throughout the presentation. We will have time at the end for some questions and answers, so I will be monitoring that and posing some questions to our speakers based on what I see in the chat at the end, so feel free to share that throughout the presentation. And with that, I am so pleased to welcome two of my HQC colleagues to the QI Power Hour today, Ala Aburab and Hamed Ejalanabu, to share with us about patient-reported outcome and experience measures. Ala joined the Health Quality Council in December 2022 as an improvement lead. He has over 13 years of healthcare experience in various quality-related areas, including quality improvement and data analysis. From 2018 to 2022, Ala worked as a continuous quality improvement officer, leading the development and implementation of patient safety culture surveys, analysis, and identification of system-level areas for improvement. Hamed joined the Health Quality Council in August 2022 as an improvement lead. Before joining Health Quality Council, Hamed worked as a quality improvement specialist with quality, safety, and strategy at the Saskatchewan Health Authority. And prior to that, he was a research scientist at the Space MRI Laboratory at the University of Saskatchewan. So I am very pleased to welcome my two very accomplished colleagues to the webinar today, and I'll turn it over to you to share your presentation.
Thank you very much, Tracy. Good morning, everyone, and welcome to our Advanced the Healthcare System and Patient-Reported Measures presentation. The aim of this webinar today is to build a general understanding of patient-reported measures, also known as PROMs and PRIMs, which are powerful tools in healthcare that empowers patients to actively participate in their care while providing valuable insights to healthcare providers. And in today's presentation, we will be exploring what patient-reported measures mean and their significance in healthcare systems and how they are transforming the patient-provided or the patient-provider relationship. And I will start off with the land acknowledgement. Today, I'm joining you from the Health Quality Council from the city of Saskatoon. The Health Quality Council is situated on Treaty 6 territory and the homeland of the Métis. We acknowledge the trauma and suffering caused by the residential schools, the 60s scoop, and the systematic racism in our society, traumas that continue to this day. And we accept our obligations and our treaty relationship and the privileges that we have, and we commit to using this privilege to further the work of reconciliation through the Truth and Reconciliation Commission calls to action. And today's webinar will be presented by my colleague Hamid and myself. We both work at Health Quality Council as quality improvement leads. We also support a few partners in the healthcare system in Saskatchewan with the PROMS and PRIMS work. And this is how our session will look like for today. So for the approximately 1 hour, we will be introducing and identifying the concepts of PROMS and PRIMS. We will also be differentiating types of patient-reported measures and briefly discuss categories for each. And we will also be describing how patient-reported measures are used in the healthcare system. And last but not least, as Tracy said, we will open a window for questions at the end of today's session. So feel free to type in your questions as we do our presentation, and we will go through all, hopefully all of these questions if we can at the end of today's session. So many of us are curious to know maybe what PROMS and PRIMS are, and maybe some of us actually have maybe some idea about the PROMS and PRIMS. So the patient-reported measures, or what we call the PROMS and PRIMS, basically consists of or let's say that whether you work maybe in the healthcare system or the research field, or maybe you are a patient and family partner, maybe you have been exposed to some of maybe the PROMS and PRIMS work. And today we will be just talking a little bit about these important measures and in the healthcare, and how we can improve patient outcomes and experiences, which is all about the PROMS and PRIMS. And the patient-reported measures consist of, let's say, 2 main instruments. As we can see, it's called the PROMS, or patient-reported outcome measures, and the PRIMS, which is patient-reported experience measures. And both instruments are essential tools in healthcare system that captures valuable information from patients and to help basically assess the impact of medical conditions, treatments, interventions of patients' well-being, and both are critical components of the patient-centered care. Patient-reported measures encompass a wide range of assessments, including questionnaires, surveys, and interviews, and even self-reported data by patients, which provides the healthcare professionals and researchers information about patients' idea about how the treatment will, or how were like their experiences. And we will talk more about these in the following slides. So these measures help healthcare provider gain insights, as we said, about patients' perspective beyond just the clinical indicators that traditionally we use in the healthcare systems, by considering patients' subjective experience and preferences during the course of care. And the information collected through the patient-reported measures plays an important role in clinical decision-making, treatment planning, and evaluating the effectiveness of medical interventions. And they are particularly valuable in chronic conditions where managing symptoms and improving patients' quality of life are primary goals. Additionally, patient-reported measures are instrumental in comparative effectiveness research, healthcare policy development, and ensuring that the healthcare services basically aligns with the patient's needs, preferences, and expectations. So I'll start off here with just a quick definition for the PROMS, or the patient-reported outcome measures. So there are too many different definitions if you go and Google it online. And looking at all these different definitions of patient-reported outcome measures, it is clear that there are too many ways basically to approach and assess the patient's outcomes. However, regardless of the specific questionnaire or survey being used, the goal is always the same: which is getting better understanding of the patient's health status and quality of life from their own perspective. And this is what's special about the prompts. So whether it is generic, specific, or customized, and these are like different types of the prompts, which we will be discussing later in this presentation, it is ultimately designed to help the healthcare provider better understand the patient's functional or physical conditions and use that information to improve the outcome of care for these patients. And by focusing on patients' prompts or by focusing on patient outcomes, basically, prompts allow healthcare providers to track changes over time, identify areas for improvement and where the care can be improved, and tailor the treatment plans to the individual needs and preferences for each patient. So on the other hand, we have the PRIMS, which is the patient-reported experience measures. And these are, again, surveys that are designed to assess patients' experiences within the healthcare services. So like PRIMS, there are different types of PRIMS that are used for different purposes, but they all have a common focus on patient's perspective or the focus on the experience itself. For example, some PRIMS are designed to assess communication between patients and healthcare providers, as simple as that. And while others may maybe focus on wait times or maybe ease of access of healthcare services or even the overall satisfaction of the, the care provided for the patients. So by collecting the data on patient experiences, within the healthcare services, PRIMS can help identify areas for improvement, as we said. For instance, if we take an example, if a hospital consistently receives low score on a PRIM related to communication, which is something that usually hospitals and healthcare services captures. So this means that, or this indicates that an improvement is needed in the communication area, and an action plan that might come up from that is provide additional training for staff members or implement maybe new policies to improve the communication with patients. So this is just like one basic example of the PRIM itself and how actually can it support the improvement in patient experience. And while PROMs and PRIMs they sound different, and they are definitely different in what information they collect. They are both important tools for assessing patients' outcomes and experiences, and they even work better when they are used together. By collecting both types of data, healthcare providers can get a complete and meaningful picture of their patients' experiences and outcomes together. So that gives like a 360 view of the patient's perception of the overall healthcare provided. For instance, if a patient reports a high level of pain on a PRIM, but also reports that their pain was well managed by the healthcare provider on a PRIM, the healthcare provider can use this information to better understand the patient's experience. They may explore whether the patient's pain is being managed in other settings, such as at home, or whether the patient may benefit from additional support or resources to manage their pain. Similarly, if the same patient reports feeling dissatisfied with their overall care on a PRIM, so that's the experience side of things, but also reports a significant improvement in their symptoms on a PROM, the healthcare provider can use this information to better understand the patient's experience and identify areas for improvement. They may, for example, explore whether the patient's care could be more patient-centered or whether maybe additional support or resources could be provided to improve the patient's overall satisfaction with care. And so, as we said, by using the PROMs and PRIMs together, healthcare providers can get a more complete picture of their patients' experience and outcomes together and use this information to improve the quality of care provided. So let's talk a little bit about PROMs. So this table basically summarizes some of the main features of the PROMs tools, or the patient-reported outcome measures. And when we speak about the PROMs or outcomes, we mainly look at patients' health status and perceived level of disability and health-related quality of life issues. These will help a caregiver understand the impact of treatment on patients and identify any future improvements that can be done to make patient physical outcome better. And when they are captured, speaking about the time, or let's say the tools, the different tools of the PROMs and PREMs. So as you can see, there are 3 different tools. We have the generic tool, we have the specific tool, and we have what is called the customized tools. So the generic tools are surveys, as simple as surveys that captures or designed to capture a broad range of health conditions or diseases. And the specific tools are designed to talk more about specific healthcare conditions and are built with a particular condition or disease in mind. And this is why it's called specific. And on the other hand, we have the customized tools. So the customized tools are basically can be generic or specific tools, but are more tailored to meet the needs of a particular study, research, or maybe a patient population. Customized tools are often used when existing PROMs, the generic or specific ones, do not fully capture the patient outcome for a particular condition or patient population. So this is when we step in and try to make modifications to the PROM tool, either the generic or specific, to make it like more customized to serve the purpose of what we want from it. And speaking about collection points, and this is very important. The PROMs can even the PREMs basically can actually be collected in 3 different stages. So it can be before the treatment to better understand the patient's outcome, or let's say patient's level of pain or condition by the time they come to get the healthcare service. And during the treatment to assess how it supports the healthcare provider or the caregiver to assess the level of how good or bad the treatment is perceived by the patient. After the treatment is also to understand how, patient's outcome expectation compared to the medical records. So that's also a very good piece and helpful piece of information that the PROM can, support understanding the outcome, like outcome for patients post procedures or post healthcare. I think I'll go. The next one is just to give some more insight about the generic tools. So this table summarizes some of the advantages and disadvantages and an example of the generic tools. So the generic tools, as we said, are designed to assess the general aspects of health or the outcomes that are related to a particular condition. And we use this tool to compare different groups of patients across different health conditions. One determinant of this PROM tool is it's less sensitive to identify changes in specific aspects of health when we actually compare it to the specific tools. Some of the advantages can be that they can be used in different patient populations. It's generic. It's like more applicable to more people. They are often shorter and quicker to administer than the disease-specific ones. And most of the basically generic tools have been developed and validated, ensuring that they are reliable and valid measure of health-related quality of life. One maybe of the disadvantages of the PROMs is that it is designed to assess the overall health and quality of life rather than specific symptoms or condition, therefore making them less sensitive to changes in the health status for patients over time than the disease-specific ones, and as they are not designed to capture the disease-specific changes, so they are less sensitive to changes. This is one good example for the generic PROM tool. So this is called the European Quality of Life 5 Dimensions, or what is known as the EQ5D5L. Again, this is a generic tool, and it is extensively used to survey the health status. It consists of 5 domains, and the answer choices are divided to 5 different levels. So speaking about the PREMS tools, so the condition-specific PREMS tools. Condition-specific tools helps to assess a specific health conditions used in diagnosis and monitoring disease progression. However, this tool is limited in scope and cannot be used to determine the overall wellness like the generic one do. Example includes tools used in respiratory diseases, cardiovascular diseases, infectious, or even like cancer diseases. So there are certain specific tools for each one of these diseases. Like most of the diseases has its own validated tools that can be used. The advantages of using the condition-specific PROMs is that it provides more details and specific aspects of health, therefore provides better understanding on patient treatment plan progression for these specific diseases and how they can improve. And some of the advantages basically may include the limited scope of these tools at specific conditions, rather than the overall health condition. Also, they might be, again, less sensitive to change in a patient's health treatment response, so like the overall health treatment response. And this can make it challenging to detect and measure meaningful improvements. I'll just give here a quick example about one of the condition-specific tools, which is called the Stroke Impact Scale, or SIS. So this is a condition-specific PROM that is commonly used to evaluate the impact of stroke on an individual's health and daily life. It is a comprehensive questionnaire that assesses various aspects of health-related quality of life, including physical and emotional, functional, social participation, and even the overall satisfaction with life after stroke. The SIS, or the Stroke Impact Scale, is widely used in both clinical and research settings to assess stroke outcomes and evaluate the effectiveness of stroke interventions. Also identify areas for improvement when it's related to the stroke treatment plan. And so we talked a little bit about the generic and specific. So on top of the generic and specific, we also have what we call the customized tools, which are tailored to meet the specific needs of a particular study. And they are designed to address the specific research or study question. It may be including modifications to the wording, or it could be a response options, like different response options to the survey or the questionnaire, or even adding more items to the questions itself. And this takes us, I think, to the PREMS, the patient-reported experience measures. So patient-reported experience measures, on the other hand, are used to assess the patient's perception of the quality of healthcare services they receive. And when we think about, the patient experience side of things, we also think about the dimensions of quality, which also captures various aspects of healthcare services that are assessed to measure their quality. And there is a very close relationship between the PREMS and the dimensions of quality, as PREMS are often used, as we said, to measure the experience, while the dimensions of quality are actually, capturing some of these experiences in the healthcare system. The dimensions of quality are typically grouped into several categories, such as clinical effectiveness, patient safety, timeliness, efficiency, and even equity. And therefore, PREMS provide valuable information about patients' perceptions of the dimensions of quality of healthcare, allowing healthcare providers and organizations to identify areas for improvement and take steps to enhance the quality of care they provide. So basically, collecting the PREMS can serve as an improvement in the experience of patients, and can also serve as an improvement of a system-level improvement in the healthcare system and the services provided for healthcare system. One example for the PREMS tool is the CARE, Patient-Reported Experience Measure, and it is used to evaluate the quality of interpersonal care provided by healthcare professionals. It consists of 14 questions that ask patients about their experience of care, including aspects such as how do you feel today? Are you feeling listened? Being respected and involved, it basically involved patients in decision making. The care focuses specifically on the interpersonal aspects of care rather than the clinical outcomes as the PROMs or the technical aspects of care delivery. It is widely used in healthcare research and quality improvement initiatives to assess patient experience and identify areas for improvement in the delivery of patient-centered care. So I've discussed a few things here about the PROMs and PREMs, and this table here is just to recap some of the points that I have discussed. As we said, we have the PROMs and PREMs. The PROMs stands for the patient-reported outcome measures. So the focus area is the outcome, while the PREMs main focus is on the experience side. And speaking about the different types of the PROMs, for the PROMs, we have the generic one, we have the specific or disease-specific PROMs, as well as the customized. On the other hand, the PREMs we have, it is more focused on the experience, and therefore these questionnaires are more looking into the satisfaction, experience, communication, responsiveness, maybe hospital cleanliness, like whatever could be or could shape the experience for the patients while they are receiving the care. And we also discussed some of the tools here, or we just give like a couple of examples here. So one of the generic tools for the PROMs is the EQ5D5L. And one of the specific tools, like a disease-specific one, is the stroke impact scale, or what is called the SIS. On the other hand, one of the PREMs tools is the care measure. I'll hand off now to my colleague Hamid, who will continue from this point and give more information about the usage of PROMs and PREMs.
Thank you very much, Ala, for giving an awesome introduction into the definition of PREMs and PROMs and the categories and some examples. While I feel that the job is done at your hand, there's one more thing we haven't talked about in this webinar series, and is how do we use the data collected from this type of measurement across the healthcare system? So for the next 10 to 15 minutes each or so, what I'm going to be doing on my own end is to let you know how the data collected from this type of measurement can be used across different levels in the healthcare systems, and with examples, of course. So giving us examples might help us reestablish the importance of why this type of measurement is needed. So like I said initially, so the data collected from this type of measurement, namely PROMs and PREMs, they're being used across different settings. And this different setting is what you can see on my slide. I regard to them as levels. So the simplest of all level we can start thinking of is the patient clinician level, which I regard to as the micro level. And then when we start looking at aggregations, we start looking at the meso level and extended far wide to what we all want, which is at the system level, which we regard to as the macro level. But one takeaway from this slide is the fact that the data we collect from each and every one of these levels, as you see them, is being used as different purpose and usage. So what I mean by this is that if you collect data at the micro level, that data has a different usage when compared to the data we collect from the clinical population level, which is the meso level. And in the following slides that you see some of the examples we've given for each and every one of this level, how the data can also be used. So, and to start this, actually, I'm going to be starting off with a story this time around. And this story is a story of patient Bob that walks into an hospital X, and at this point in time, the patient has a medical condition X. And what happens? When he sees his doctor, according to ALA, we can collect patient-reported outcome measures or experience measures at different stages, whether before treatment, during treatment, or after treatment. The physician encourages him to fill out an experience measure and also an outcome measure. So basically, what we're using the experience measure to do is, well, what was your experience when you came to the hospital? So outcome measures is all about the conditions itself. So this patient is enabled to input into his own care. And as a result of that, what we use data for at this stage, at the micro level, is for better communication between the patient and the care provider. So I say most of the time that a huge part of the data we collect at this stage is meant for clinical practice information and to enhance patient engagement. So as a result of this, if the patient fills out a PREMS and PROMS and we collect the data, the physician in charge can actually measure or monitor the progress of the patient outcome. Now we've left the single level, which is the micro level. We're going into the meso level this time around. And the same story applies. Patient Mary goes into an hospital with condition X. But at this time around, not only our information was collected, a bunch of people having similar condition with Mary, their information was also collected alongside with Mary. So what can we use this type of information for? So this time around, we are aggregating information from different people that have similar condition. And we can quickly think about 2 or 3 reasons why we could collect this type of data at this level. So one of those reasons is that we could aggregate this data and we can use it to assess or monitor the outcomes of this set of people having this condition over time. Another thing we could use it to do is to actually identify gaps in the care that we're giving patients. And lastly, if we have specific programs in place in this particular clinic, we can use the data collected from this type of level to evaluate the effectiveness of our program. For example, we start looking at, well, is our program really working fine or not? Do we need some kind of adjustments and things like that? So at this level, this is the kind of data collected is used for this purpose. And again, I'm going to be giving us several examples on this, on how we can use the data collected from this level to evaluate healthcare programs. So one of the examples that comes to mind strictly is the Canadian Longitudinal Study on Aging. Typically, most people in the healthcare sector know about this type of study. And this study is a long-term study that's been conducted in Canada. And the aim of this study is majorly to understand how people age, and also what are some of the factors that can contribute to healthy aging here in Canada. So what did they do with this study? So what they did was that they surveyed 50,000 individuals, and these 50,000 individuals have age group 45 to 85. And what we're looking at rather is how do we assess over time the changes in their health, social, and maybe economic well-being. So what they did was to distribute PREMS and PROMS this time around. Of course, you know what they do, outcome measures and the experience measure, to collect information about the health and well-being of these individuals. And some of the information that we're collecting include, well, are you functioning physically? What about your cognitive function? What about your mental health? Do you have any kind of social support? What is the quality of life? What does it look like for you? And again, Hala has actually alluded to the fact that we call something AQ5D5L that can be used to assess the quality of life. In terms of this, most of those questionnaires were being thrown out to assess their quality of life this time around. And they also did something like an experience measure to know if some of these older adults are actually receiving the care they need to. So what did they come out with from this research? So the premise and prompts that have been distributed or have been used in this survey investigate a range of research questions. So they started looking at factors such as chronic disease. How does it really contribute to the aging process? How does social and economic well-being of people in this region, how does it actually affect their aging process? And what they came out with as a result of this study was that there are three factors that affect elderly aging in Canada. One of them is physical activity, the second is social connectedness, and the third is access to healthcare. So from this result, there were different policies and programs that were being put in place to support elderly aging in Canada. So, and that is one example of how the data collected from the meso level, like I said, it's more about the aggregation this time around of the data collected from similar people having similar conditions was being used in order to evaluate programs and put in place programs that would benefit the society. So most of us seated on this table that are well known to quality improvement, that are in patient safety rather than quality improvement, they typically know that fall prevention is a big thing in patient safety. So this is also another example of how we incorporated patient voice into fall safety, fall prevention rather. So the three interventions this study wanted to look at. One of those interventions is that, well, which one is the most effective method for preventing fall? Do we use non-slip socks? Do we use education? Or do we use a chair alarm? So again, those in quality improvements know that we do something which we call the Plan, Do, Study, Act, PDSA circles, most of the times when we're testing ideas. So the first thing that was done was that we conducted this, and for some of us that do not know about that, the plan part of the PDSA circle is that, well, we have several interventions. How do we plan it out? Just the normal planning. And the D part of it is do, actually do the thing. And the third part of it, which is study, is that, well, what are some lessons we've learned from what we did? And you act based on that lesson. That is the last A part of it. So a PDSA circle was conducted for all these three interventions. However, this time around, this PDSA circle was not only done in isolation. What we did was to incorporate patient-reported outcome measures with it. We wanted to hear the voice of the patient this time around. So what did this lead to? Although the PDSA circle actually shows that the non-slip socks were mostly effective in preventing fall. However, when we heard from the patient, and when they did the study, what they heard from the patient is that some of the non-slip socks continues to give them allergies. So hearing from the voice of the patient makes them to turn around the kind of intervention they want to use. So instead of using the non-slip socks that the PDSA circle has suggested to be effective in the first place, what they did in essence was to use a combination of education and chair alarm. And that is also another example of how we had patient voice and incorporated it into decision making. The last part of everything is all about the system level. This is where we want things to happen, basically. But are we acting towards it? So the data collected at this level is used at the provincial level for comparison or at a jurisdiction level. This time around, let me say we have some intervention in Saskatoon, for example, and we have other intervention in Regina. If we consider Saskatoon as a jurisdiction and Regina as a jurisdiction, we can start comparing data that we obtained from both jurisdictions to see what happened. So, and of course, those in quality improvement know again that if you start comparing data like that, it leads to variation. And variation itself is the mother of improvement. So, so the premise and prompts data we collect at this level is used to evaluate the performance of our healthcare system by incorporating patient voices, of course. And we can use it to make policies and decisions in our healthcare system. Also, we can also use it in service allocation most of the time. if you've seen from the example I'm going to give in the next slide, if you've seen that this particular region lacks something, then you could also use the data collected to intervene in those kind of things. So one typical example most people know about, stated on this table, is the CAHI study in 2017 done for hip and knee surgery. And I know recently there's a learning health system project on that, basically in Saskatchewan going on. So this CAHI study was conducted across provinces. And the aim of the study itself is to collect PROM data from people that have gone through hip and knee surgery. Most of the provinces in Canada went through this. So what lessons did we learn from this study? So the lessons learned from the project enables comparison of existing clinical infrastructures across provinces. It was from this study they started knowing that, well, this particular province has this particular province does not. Like I said, it's more variation. You start seeing variation if you compare data across jurisdiction, and that actually informs the health policymakers on so many things about standardizations and how can we plan maybe for uniformization and things like that. So these are typical examples of how we can use PREMS and PROMS data across different levels in the healthcare system. And I should reiterate one thing at this point, that the data we collect from each of these levels are different in usage and purpose, like I said from the beginning. And that is one take home. You collect data at the micro level. That data cannot be used at the system level. They are meant for different things. So that is one thing that I hope to iterate over and over. So this presentation today won't be complete if I do not take us through PROMS and PREMS journey in Canada ever since inception. So these were a list of key dates, and there was a bit of progression on what we did in Canada on PREMS and PROMS. In the early 70s, basically, researchers started gaining insight into PREMS and PROMS, and they started thinking about how they can incorporate this type of measures into healthcare assessment. So when it got to 1990s, there was some typical research that was being done on PREMS and PROMS by researchers in several clinical areas. In 2020, in the early 2000 rather, several Canadian provinces such as British Columbia, Alberta, and Ontario, they started bringing effort out into, well, how can we incorporate this type of measures into healthcare assessment and quality improvement? And in 2008 specifically, which is more like a milestone, the Canadian Institute of Healthcare Information, which we know as the CAHI, what they did then was to launch the first Canadian patient experience survey, which can be used in hospitals. So this was more like a major landmark or milestone in the development of PREMS and PROMS in Canada. So in 2010s, we started standardizing and expanding the use of PREMS and PROMS. A lot of people started hearing about it. The CAHI and most of the provincial health authorities in Canada started collecting data on this on a rapid scale. And that was when PREMS and PROMS was fully blown in Canada. And in 2014, there were some publications done by CAHI and things like that. So going on to 2016, which is something which is also interesting at this point in time, and we should start thinking about that, is the integration of this type of measures into our electronic health record systems. So people started talking about that and how we can utilize this type of measures in our electronic health record system. And interesting conversations spring up from that. How can we store this data? This data are going to be stored in the cloud, and which I think mostly is interesting. And ever since then, there have been ongoing advancements in the use of PREMS and PROMS. Like I said initially, in Saskatchewan, we did the provincial stroke pathway strategy, and so many things started springing up as a result of that. And also, we started using PREMS and PROMs in various clinical specialties up to date. So why did I actually illustrate this journey? I didn't illustrate this journey for anything. It's just for us to know there are a lot of people seated at this table today. And we at HQC, we are majorly champions of this. And the reason why I have illustrated this journey is to let us know that each and every one of us have a role to play in the development of PREMS and PROMs. You're a researcher seated at this table. You're a patient, you're a clinician. I know most policymakers are seated at this table. So there are a lot of work for us to do when it comes to championing PREMS and PROMs in our province, most especially from the leadership and the management perspective. As we're looking at it, we should not only be responsible for funding research that goes into PREMS and PROMs, we should also encourage collaborations. And also, after this result have been gotten, because a lot of research have gone and we collected a lot of data and things like that, how do we plan at the management level? How do we plan to incorporate these patient-reported outcome measures into our healthcare policy should be one of the messages we are passing across today. So lastly, I would say we've talked about a lot of things and we're giving space and time for a little bit of question and comment at this point. And to summarize everything, I and my colleague have actually done different things. So in this lecture today, we talked about the differences between the patient-reported measurement tools. We talked about the categories, some of the examples. We also described the uses of PREMS and PROMs across multi-levels in the healthcare system. And lastly, I was able to expatiate on the fact that everyone has a role in the development of PREMS and PROMs here in Saskatchewan. And thank you very much.
Excellent. Thank you so much, Hamid and Ala, for sharing your presentation, for sharing the information about patient-reported outcome and experience measures, and for the wonderful examples you've provided of how they are used in practice. I've noticed there's some lots of questions being posed in the chat, so I'm going to dive right into those. So I did notice Melanie had asked about databases available of validated experience and outcome measures. I noticed, Melanie, you indicated later a couple of databases you're familiar with. Thank you so much for sharing those. And that Ala, you have shared a link of your own. So I think what I'll do there is draw everyone's attention to those links in the chat, and feel free to check those out if you'd like to know what kind of tools are out there that you can maybe use in your setting. With that, I'll move on to the second question asked by Peter. And Peter, my apologies, I'm not sure if I totally understand your question here, so I'm going to do a little interpreting. If I've gotten it wrong, please correct me in the chat. But you've asked about, can you speak to the costs of healthcare delivery combined with PROMs, and specifically non-health technology assessment of comparing outcome improvements per dollar spent? So I think what you're asking about here is incorporating, a measure of cost or value in with patient-reported outcomes. Is there a way of looking at whether improving those outcomes, have a return on investment or improve outcomes related to cost, I think. So Peter, I'm sorry if I've gotten that wrong. You can correct me in the chat, but Ala or Hamid, any thoughts on that?
So to answer that question, no, we haven't done that kind of analysis before, but in actual sense, it's going to be very interesting to check out. One thing I know for sure is that there's going to be a huge return on investment, tangible or non-tangible, this time around, by the incorporation of this type of measures into our healthcare system. But specifically for the question you would ask on, have we done some kind of analysis? No, we haven't done those type of analysis, and that puts me on the spot that maybe things like this should be done definitely. Thank you, Peter.
And thanks, Peter, for your confirmation that I did interpret your question correctly. I might offer that I do know that when you think of the more generic tools, the other benefit of those is I think there has been some work done on validating the usage of those to look at economically adjusted quality of life measures. So there may be a link there that you could explore. All right, so I'm going to go back. There's lots of questions here in the chat. I'm hoping we can get to them all. Jennifer asks, is there a correlation between patient-reported outcomes and patient-reported experience measures? So I know you showed earlier there's a bit of a Venn diagram of how those two interact. Have you found in your journeys through this linkages between good experience and good outcomes, for example, which I think is what you're asking about, Jennifer?
Yeah, I can jump in here, just try to answer this question. So the answer in short is yes, there's a correlation between both of these. So first of all, if we look at the PROMS and PRIMS, both of the tools are actually capturing patients' journey in treatment, the outcomes and experiences. So that's like the first correlation, it's the patient's perspective. The second one is when we think about it, if we meet patients' expectation in the healthcare system, it means we are meeting the way we can meet the patient's expectation is meeting their outcome expectations as well. So I can't really think of an example of how can you meet patient's expectation if you can't meet the outcome. So there is a strong correlation between them, although they completely capture two different perspectives, but they are very connected at the same time. I hope this helps.
Excellent. Thank you. Yeah, and if you have a follow-up, please feel free to enter that in the chat. The next comment is from Rosalie. I think this is more a comment than a question, but I'll pose it and then Alaa or Hamed, if you have anything to comment, be happy to hear that. So I think the comment is about studying an intervention and incorporating the client or patient's perspective using a patient-reported experience measure, and that fall prevention example is interesting. That chair alarms are not evidence-based, so I'm assuming the questions and studies need to ensure evidence is existing. So, you know, it's an interesting comment when we have evidence from the literature of something that might work in a potential situation. When the patient's experience of that intervention or that evidence-based practice might differ or might not be positive. So curious about, you know, any other examples you might have found in your studies on this, and what people have done in that situation where the experience of a patient has maybe contradicted what evidence has said is effective.
Rosalind and Tracy, thank you very much for that. So do we have more examples on this? Just like you said, sometimes there are things that are not evidence-based, but just because patients said it, we want to incorporate this. So one thing I agree with Rosalind on this is that there's a need for us to collect more evidence-based measures before we incorporate this. But in this particular study, it was basically a research study, right? It was not something that needed to be implemented. We just needed to see, well, if we incorporate patient voice, what happens afterwards?
Great, thank you. Thank you so much for all these questions. I'm hoping we can get through them all. And so to help do that, I'm going to combine a couple that I think are similar. So you talked a bit about the different levels that you can measure at. So the micro, the meso, and the macro. And I think there's, you know, some questions, and I think you may have made a comment about the challenges of using micro level measures for macro level change, and how measures at those different levels, you know, might interact with each other or might be used for different purposes. So do you want to say a little more about that? What might be some of the challenges of using micro level measures for macro level change?
So this time around, and that is one of the problems about collecting data. And one thing I usually say is that you collect data, let's take for instance, but are you using it for what you need to use it for? So like I alluded to recently, that at the micro level, it's just meant for interaction between the patient and the physician. It's meant for communication. It's meant for personal things. But when you go ahead to the next level, which is the meso level, you're looking at aggregation this time around. So you averaging things out is a different thing entirely. So this time around, we're looking at average across the set of people that have similar conditions. So collecting data at different level is definitely different, like we've seen. But are we collecting the right data for the right purpose should be the question. So if you collect data at the meso level, for example, we're using it for something different, like I've said in my presentation, compared to when you collect it for the micro level. So some of the, like you said, some of the dangers of collecting data that is meant for a particular purpose and using it for a different purpose is that you might not even find intuition into the data itself. Let's say, for instance, you're collecting data at the meso level and you aggregate things off, and you want to use it for the micro level. It doesn't really speak to the individual involved. So the main point here is that, are we really collecting data for use for the right purpose?
Great, thank you. Yeah, and I think, how I'm interpreting what you're saying is that it's not necessarily a hard and fast rule that you can't use data collected for one purpose for another. However, when you do that, it can present some challenges, both, in terms of method. Sometimes when we're collecting it at a micro level, there's a level of customization that people may want that makes it difficult then to aggregate it to a higher level. And also, you get into statistical things like adjustment and sampling and issues like that when you're looking at a macro level. So it's not to say you can't do it. It does present some challenges, though, when you're serving multiple purposes, for example, with maybe one tool. Thanks so much for that answer. Okay, I'm going to, I think, combine a couple of questions here, and we may have time for one more after this. So I'm just scrolling through here. So I think there's a couple of questions related to, is it possible or advisable to collect, demographics along with patient-reported experience or outcome measures? If you want to say a little bit about that. And then, the question someone's asked around privacy, which I think is related. So how do we ensure the privacy and the security in collecting this data, especially if we're going to add identifiers or demographics to that equation? So would you like to comment on that a bit?
Oh, yes. So in fact, there were different research we did using prems and proms that we had to collect demographic data. So if I'm getting you correctly, maybe the question says that, is it advisable to collect demographic data? Right? So in some instances, if you're looking at a particular demographics or group, it's advisable to collect them, but without identifiers this time around. So because the kind of what we did, it was a long COVID national project. And we needed to know how long COVID actually spreads across the given demographics. So what we needed to do was to collect the demographics indicating, well, what is this time around, what is your age? Where do you live? We needed to know that spread across the province. So the other thing that was being asked was that, is it advisable to do that? Based on the kind of research you're carrying out, it might be advisable to collect demographics this time around. Also, there's no hard and fast rule about it, but how do we maintain confidentiality and security around this? It's actually a very huge topic, and I think it's another QI power itself. Not really, it's not in my own warehouse. I can't really say much about it, but I know it's something which other people have dealt with, and they're doing very fine with it.
Great, thank you so much. Well, thank you so much to everyone listening for your lively discussion in the chat today and all of the questions you've asked. I know I've missed some, my apologies for that. However, we are at the end of our time. So feel free, to continue discussing in the chat as you have been as I wrap up the webinar. And I'm sure both Ala and Hamid would be happy to have further discussion after if you'd like to reach out. So I'm going to wrap up. So Ala or Hamid, if you can just pass the presenter function to me. And I want to give my thanks to the two of you for sharing this presentation with us. I know there were a lot of kudos in the chat, and I want to give you mine as well in all of the information and examples that you shared in seeing what can be done with patient-reported experience and outcome measures. And for anyone out there who's listening, if you have a topic you'd like to share with our QI Power Hour community, we would really love to hear from you. And all of our speakers get, as a token of our appreciation, a pair of I Love Quality Improvement socks. And so if you'd like to share your idea, please reach out at the link on our website to learn more about how you too can become a QI Power Hour speaker. When you leave the session today, you will be taken to a post-webinar survey. So you'll get a little warning. Don't be alarmed. You can click on that link. It is safe, and please do so and give us your feedback on today's session. We do use that feedback to continuously improve how we deliver our QI Power Hour sessions. So thank you in advance for sharing your feedback today. And I'd really encourage you to join us at our next QI Power Hour session on November 24th, where we'll be pleased to welcome another one of our HQC colleagues, Dave Broda, to speak about leading change and change management. So thank you again to our speakers, Ala and Hamid, for sharing your presentation with us today. Thank you to all of you for joining us and for your lively discussion and questions in the chat. And we look forward to seeing you next time. In the meantime, take care. Bye, everyone.